Hello, everyone, and welcome to today's webinar. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone require operator assistance during the call, please press *0. Web participants requiring support should use that chat feature on your screen. I would like to now turn the meeting over to your moderator today, Julie Drury, Strategic Lead at CFHI. Please go ahead.
Hello everyone, and welcome to today's Spotlight Series webinar, Better Together, the Reintegration of Family Caregivers as Essential Partners in Care in a Time of COVID-19. I'm Julie Drury, the Strategic Lead for Patient Partnership at the Canadian Foundation for Healthcare Improvement. CFHI works shoulder to shoulder with partners to accelerate the identification, spread, and scale of proven healthcare innovations across the country, and we aspire to be an indispensable partner in shaping better healthcare for everyone in Canada. Our Canada's healthcare improvers and innovators to shed light on ways to address the most pressing challenges in healthcare across Canada. I'm pleased to be facilitating the webinar today alongside my co-host, Dr. Ward Flemons. Ward, I'll invite you to introduce yourself to the group today.
Thanks, Julie. Good morning, everybody. I guess it's maybe afternoon for some people. My name is Ward Flemons, as Julie mentioned. I'm a respirologist from Calgary. So I work within Alberta Health Services, University of Calgary. I'm also a medical director with the Health Quality Council of Alberta.
Thanks so much, Ward. And Ward was an integral member of our Rapid Response Expert Advisory Group who helped us to develop this report that we'll be discussing today. Just a friendly reminder that we are recording today's webinar and we will be providing the archive on our CFHI website in the days following. We're pleased to host the Spotlight Series webinar bilingually, including this webinar. So the telephone number to connect to the French audio should be on your screen, and we invite you to use either official language when entering your questions or comments in the chat box. And we will try to get to your questions, comments, and observations in the chat box during our discussion with our panel today. I do want to begin this webinar by acknowledging that we are meeting on land that has been inhabited by Indigenous people since the beginning. And in particular, I would like to acknowledge that we are broadcasting this webinar from Ottawa, which is the traditional unceded territory of the Algonquin and Anishinaabe people. I'm very proud to live in this beautiful city and recognize and deeply appreciate the historic connection of the Indigenous people to this place. So let's get to the focus of today's webinar. We're going to talk today about a couple of things. We're going to review, we're going to learn, and we're going to discuss the role of family caregivers as distinct from visitors as essential partners in care. We're going to talk to our panelists and learn from them their experiences at the healthcare systems level from our incredible team at Alberta Health Systems in Alberta, obviously, from an incredible hospital CEO in Ontario, Dr. Jillian Kernahan, and her leadership during this time of COVID. And we're also going to hear from two incredible family caregiver partners in care, Sandy Opal from Alberta and Marianne Lavasseur from Quebec, to hear about their lived experiences, in particular in this time of COVID-19, as family caregivers and the essential role they play. And then we're going to discuss, and that's going to be the most exciting part, I think, of this webinar. We're going to bring all of you into the conversation. Ward and myself are going to take our panel through some great questions and hopefully get into a discussion as to the context of family caregivers as essential partners in care, why it's important, how we can bring them back, what some of the challenges are and barriers, and also what some of the solutions are. Really looking forward to having that conversation with you all today. A little bit of history and context about Better Together. Over the last 5 years, the Canadian Foundation for Healthcare Improvement has been working directly in this area of the healthcare system, and that is to support the presence of family caregivers as part of healthcare teams across Canada's hospitals. As reported in Much More Than a Visitor, a report that we just recently released, from 2015 to 2020, we saw a change in family caregiver presence in hospital settings across this country that went from 32% of accommodating family presence policies to 73% in winter 2020. And that change, in our estimation, really demonstrates the commitment to creating environments that are supportive of patient and family partnership in care, and that deep appreciation of healthcare teams in partnering with family caregivers to support patients who are in hospital. We all know that COVID-19 truly hit our country in early March, and that we went into a state of blanket visitor restrictions. And so the situation changed dramatically. We did a very concise review of 32 hospitals across the country that we have been working with, and we saw a change in that rate of accommodating family caregiver presence policies that went from the 73% mark down to close to zero of blanket visitor restrictions. And while at the time we saw that as something that, that perhaps made sense and in the short term was necessary, but as things have progressed, we recognize that there is a need now to look at how we can effectively, safely, and efficiently bring back that role of family caregivers as partnering in care directly with their loved ones. So to develop the report, Reintegration of Family Caregivers as Essential Partners in Care in a Time of COVID, the Canadian Foundation for Healthcare Improvement surveyed current provincial and territorial guidance, recommendations, and policy. We looked at regional and hospital policies. We reviewed the existing literature in regards to family caregiver presence. And we conducted key informant interviews across the country with healthcare system leaders, frontline staff, patients, families, and caregivers. And then we convened our rapid response expert advisory group. And this group was composed of clinicians, healthcare system leaders, hospital CEOs, experts in legal and bioethics, public health experts, and of course, as with anything that CFHI does, we work very closely with patient, family, and caregivers, and they rounded out our expert advisory group. This group also reviewed the evidence. They familiarized themselves with the current provincial and territorial visitor restrictions as they were evolving, and they provided their expert advice, their experience, and their lived experience about how we could balance the potential benefits and harm for patients, families, and caregivers, and the healthcare system as a whole. They came to a consensus and wise counsel about the next steps that we're going to discuss today about how we could guide hospitals across the country to reintegrate family caregivers as essential partners in care. I'm going to ask Ward to introduce us into how to move ahead.
Okay, thanks, Julie. So the advisory group identified 7 key steps, which we'll cover in the next few slides. And these were steps to move forward, hopefully for the healthcare system across Canada, and looking at reintegrating family caregivers and considering them as essential partners in care. One of the important things was to identify, so what was the audience for these next steps? Who needed to be influenced in order to consider this as we move ahead with this COVID crisis? And the audience was really identified as health authorities at the provincial territorial level, regional health authorities, medical officers of health, hospital senior leadership, boards of directors, clinical staff, patient relations and patient engagement teams, research and academia. So really a broad swath of people that need to come to the table to discuss this. And so across the healthcare system, a considered approach of the required actions for each of these steps is going to be important. And so I'll just highlight in the next slide the 7 key steps that this advisory group came up with under the direction of CFHI. And the first one was to ensure a foundation of patient and family partnered care, really to get back to that, even in the setting of COVID and the high risk that represents to our healthcare system. Second was to revisit policies on family presence with patient, family, and caregiver partners at the table. So rather than make these decisions in isolation, and sometimes we have a habit of doing in healthcare, get the patients at the table to view the options that we have. Third was to distinguish between family caregivers who are essential partners in care and visitors, so not a blanket policy on all people who are not healthcare providers directly, but make a distinction between essential caregivers that are family-based. Fourth was to consider the needs of people who face specific risks without the presence of family caregivers as essential partners in care. So really to identify those people that absolutely need to be with patients. And therefore, number 5 was to take a comprehensive, balanced approach to assessing risk, and not just assessing the risk of spread of COVID within our healthcare system, but to look at the downside of keeping patients, essential caregivers, outside of the care environment. 6 was to establish a rapid appeal process, so if families couldn't agree on that, to have some recourse that they could talk to the healthcare system and maybe have a second considered opinion. And 7th was to increase the evidence to guide decisions regarding family caregiver presence. And we know decisions are being made quickly, and sometimes there isn't a lot of evidence to base them on, but to continually update the evidence so we're making the best decisions possible.
Thanks so much, Ward, for taking us through those 7 overall overarching themes in terms of our next steps. Ward and I are now going to walk you through a slightly deeper dive, and if you've read through the document, this will be familiar with you. And this is in terms of the actual sub-steps, I guess you would call them, under the next steps that the Rapid Response Expert Advisory Group articulated. And so Ward talked about ensuring that foundation of patient and family-centered care. I can share with you both anecdotally and through our key informant interviews with caregivers, have become accustomed to engaging with different sectors of our healthcare system in advisory capacities, in partnership capacity, and also collaboration. But they saw a significant shift in that as we entered this pandemic crisis with COVID-19. And in many instances, that partnership in developing program and policy was lost. And likely a result of having to move quickly, of healthcare systems really trying to respond in real time to significant challenges to our healthcare system. And so we're calling for a shift back to that, that foundational patient-centered and patient-partnered philosophy. What is the best for the patient, and looking at all aspects of that idea of what is best in a patient-centered and partnered system. And the only way we could truly get at that is ensuring that we have patients, families, and caregivers who are informing, partnering, and collaborating with us on that work. So that's our first call in terms of our next steps. The second is revisiting policies on family presence with patients, families, and caregivers at the table. That lived experience, expertise, cannot be undermined and undervalued. Truly, we need to ensure that as we reintegrate family caregivers as essential partners in care, we're collaborating with them to help them understand their role, to help them understand what has changed in the time of COVID-19, and to bring them back safely and effectively. Of course, we want to consider regional, local, and hospital-specific circumstances when supporting that reintegration role as well. Incredibly important, as every hospital, and we're seeing across the country, different jurisdictions are having different challenges with COVID-19. And so that will have to factor in as well in consultation, again, with those patients, families, and caregivers as to what is safe to bring them back. And then lastly, and not least importantly, is supporting hospital staff, frontline teams, to first of all understand that critical role that family caregivers play as essential partners in care, and to help them feel safe and understand that family caregivers can come back, that it can be safe, that it can be well supported, given the right tools and resources. And we've noted many of those tools and resources in our document. Step 3 and 4, again, this is adding more context around the critical steps that we've outlined in our document. So step 3 is very much about distinguishing between family caregivers who are essential partners in care and visitors. And so this is really important, right? This is about language and really effective communication. And I think we lost the message along the way that family caregivers are hashtag more than a visitor. And you'll see that hashtag throughout our document, You'll see it in social media. You'll see family caregivers referencing it regularly. There is a distinction, and it's very important in the language that we're still using, where we're talking about visitors as a broad way of describing anyone who partners in the healthcare system. Visitors are people who are there to visit. They're not directly engaging in care. They're not directly partnering in care. They have not been designated by the patient as someone who they need at bedside to partner in their care. So we want to ensure a clear understanding of that definition. We also want to ensure a clear understanding about whose authority determines the interpretation of provincial territorial guidance around who's deemed essential. This has been a significant challenge, not just for healthcare workers and organizational leaders, but as well for patient, family, and caregivers. Who makes that specific decision as to who is an essential partner in care and who is not? We want to address the inconsistency in the application of some of the recommendations and directives. Again, this has been a significant challenge for healthcare leaders across the system and for patients, families, and caregivers. What directives apply and when, and who is accountable for them. And again, supporting that awareness, that increased awareness of the distinction of the definitions of essential care partners and visitors. Ward alluded to step 4 that we had identified in our next steps the consideration for needs of people who might face specific risks or vulnerability without a family caregiver present at their side. And so we're asking hospitals and healthcare system leaders to think about the inequities that could occur in care for some populations where the absence of a family caregiver as essential partner in care might result in additional risk and unintended harm. As a foundation, as an expert advisory group, we've all agreed that a patient has the right to ask for that family caregiver presence, and that really needs to be respected. But we do feel there are specific populations where their risk is increased. I'll offer you a few examples. Persons who have challenges in communicating, developmental disabilities, cognitive disabilities. Persons who have dementia or difficulties in understanding information and being able to communicate with their healthcare team. Persons who have have just transitioned from pediatric care to adult care and have had such a shift in responsibility as a young person that they need that ongoing support of a loved one or a family caregiver. And those are just a few of the examples that we've included in our report to talk about those populations where the absence of a family caregiver could increase the challenges to safe and effective care. Ward, I'll turn over you to take on the next few steps.
Okay, thanks, Julie. So step 5 was really about looking at managing the risks and balancing those risks. And we all got used to thinking about the risk of COVID-19 in terms of the impact on our patients, ourselves, our caregivers, and doing everything we possibly could to prevent the spread of COVID, both in the community, but particularly inside the hospitals. I can tell you from firsthand experience, one of the greatest fears I think we all had was that our unit, our place where we work, might be a place of outbreak where somebody might have lapsed in their use of personal care devices. So, but we didn't, in my opinion, really balance the risk against, well, what happens to the patients and their families when they're separated and not allowed to be together during these crises. And I had, again, some personal experience of a friend actively dying whose family was slowly shut out of the care, his care as he passed away at the end of March inside one of our acute care institutions. So that was heartbreaking to see, and I think long-term effects on his family. Step 6 is really about establishing a rapid appeal process. So once the policies are made and once the procedures are developed for how families can be considered essential caregivers, if there's a disagreement, how do those get resolved very quickly, and what processes can be put in place by healthcare institutions in order to fairly evaluate those differences and really help to manage the risk. So those are and then the final step in the next slide is step 7, And step 7 was to continually look at the evidence of, so what is exactly the risk of COVID spread within hospitals by visitors coming into the hospital? Can we use the evidence to help guide our policies and therefore our procedures? And can we use that evidence to help us learn how to minimize the risk? We'll never eliminate the risk, but minimize the risk so that we can get that balance right between keeping the hospitals as safe as possible, but also not at the expense of divorcing patients from their family caregivers. So prioritizing research and looking into the impact of that critical component of caregivers inside the hospitals, and really looking at those caregivers as part of the caregiving team, and we wouldn't exclude nurses or physicians or respiratory therapists or occupational therapists from the caregiving team. So if we consider patients' families members as essential caregivers, then how do we minimize the risk and look for the evidence for that? So I think we're going to move on to hear from our expert panel members. And first we're going to hear from 2 of my colleagues in Alberta, who I haven't had the pleasure of meeting, but Sandy Opal is a patient partner for Alberta Health Services, and Chris Mayhew, a senior consultant in engagement and patient experience. So first-hand experience and then organizational experience of how to engage patients and how to think through this issue. And so take it away, Sandy and Chris.
Great. Excuse me. Thank you. So with this first slide, actually I won't spend a lot of time talking about it. I really want to focus on Mars, but just to give a bit of context, as folks are probably aware, Alberta Health Services is Canada's largest and first integrated healthcare system, and you can see by the numbers sort of the scope and magnitude of kind of the system that we're dealing with in terms of the amount of employees and sites. I'm going to go on to the next slide. And for this slide, I'm actually going to introduce Sandy into the conversation to start to reflect on her experience and kind of what it's been like in recent years. So take it away, Sandy.
Thank you, Chris. My daughter is now a 22-year-old, and after years of supporting my kiddo in a pediatric setting, it was really quite shocking to enter adult care. We entered it with a bang of having multiple admissions and numerous lengthy stays. In the beginning, I remember having a need to really advocate for my own needs as a family caregiver over the last 4 years. But I've really seen an evolution of family presence with the elimination of visiting hours and actually being welcomed into the care and being part of the care team, regardless of the unit or the area that we have experienced.
Great. Thanks, Sandy. And so, you know, we're trying to create a little context. Certainly, as Sandy had mentioned, over the last number of years, we have been doing work, and like many of you on the call, we've been on a journey to looking at how do we improve the patient experience, including family presence. Certainly, shortly after the Better Together initiative that was sponsored by CFHI, Alberta Health Services approved an organizational-wide family presence policy in 2017. And while that policy established a number of foundational principles for family presence, champions within our organization soon identified that there was a real need and opportunity to raise the bar and to go to an approach that really promoted meaningful partnerships with families. So in late 2018 and early into 2019, we committed to a review and revision of our current policy and began extensive engagements within AHS programs and services. We also connected with the Canadian Foundation for Healthcare Improvement and consulted with a number of our provincial colleagues and did a literature review to really kind of understand sort of what was leading practice. A key part of this development was also working with our AHS Patient and Family Advisory Group to co-design the policy, and we did additional validations with a number of patient and family advisory groups across the province. In total, we completed 45 AHS stakeholder consultations with 20 different groups over a period of months. So a valuable engagement mechanism that we've came across was the community of practice for family presence. And we created this group to really help support sharing of information, to really share successes and challenges that people operationally were experiencing, our staff, and to really look at solutions. So it's been a really fruitful mechanism to really bring people together and to come up with ideas and really spread our practices. So that was the pre-pandemic situation, and we're going to transition to what the COVID-19 response is. And I'm going to bring Sandy back to the conversation to share what it was like more recently.
Thanks, Chris. Well, during COVID, we actually experienced multiple admissions, and I just want to highlight a recent experience of having to wear a visitor label at a recent ED admission. It really struck me, and the language of that really struck me to the core, both as a family member but also as an advisor. I posted on social media how this label seemed so very wrong and didn't actually match my experience at all. I was so concerned that we were going backwards, especially in regards to the language, in regards to patient family-centered care. Since that post, I've been approached and invited to share our experience with the family presence community of practice, as well as present in a practice-wide session for AHS staff, and subsequently invited to participate in this webinar to really reinforce the power of language and the need to recognize that there is really a difference between being a family caregiver and a visitor, as well as the importance of including the family voice as we move to a future of living with COVID.
Thanks, Sandy. And yeah, you know, certainly as Julie had mentioned, the experiences of our families are so critical and vital to informing this process going forward. And folks like Sandy and our other patient advisors are really essential to kind of bring that voice and that experience to our work and how we plan to go forward. So, you know, in AHS, like lots of other jurisdictions, we did implement a no visitor policy in April, you know, and to meet that immediate need, as Julie had mentioned, around, you know, ensuring safety and doing the right thing to do that. But, you know, we came to the realization that, of course, that needed to shift. At the time, we actually had a number of staff from our engagement and patient experience team that were redeployed to respond to an increase in calls with our patient relations department. And certainly the feedback was that many of these calls were related to visitation issues and the limits that had been enacted. The data from patient relations confirmed this, that there was significant increases in those types of calls. At the time, and still, our AHS Emergency Coordination Center was leading the organizational response for COVID, including the visitation restrictions. And so we reached out to offer our support based on the knowledge that we had established, you know, in our policy development work and working with our patient advisors. And our offer was certainly openly received to provide input. So at that point, you know, for a while, of course, our engagement of patient advisors have really slowed down, and we really wanted to seize on that opportunity to bring them back into the fold and to really provide that response and reinforce some of the issues. And you know, one of the issues that they reinforced was around the language, as Sandy had mentioned, as well as other key considerations. So we submitted those recommendations, and there was a request to pull together a advisory task force around family presence, and really representative of a large number of stakeholders across the organization. And so based on the advice of the group and, you know, our input, ongoing input from our advisors, we issued our first revised guidance around designated family and support guidance, and that was certainly wanted to bring the different naming into effect to recognize. And that was on June 5th, and that provided a broad provision for 1 to 2 family support members to be present with patients and not be based just on exception basis. After that, we've certainly been leveraging our established patient family-centered care networks and consulting on changes and also the challenges, and really looking, continuing to move forward with revisions. So that's a snapshot of what's been happening with Alberta Health Services. Thanks for the opportunity for sharing.
Good. Thanks.
Thank you so much, Chris
Sandy.
and Sandy. Sorry, go ahead, Ward.
Yeah, no, I was just going to say thanks to them both very much.
Yeah, and particularly you, Sandy, for sharing some of your experiences and your journey in this time of COVID. I remember you sharing with me just recently that your daughter was hospitalized pre-COVID, and then the blanket vision restrictions hit while you were actually in hospital with her, and can imagine how challenging that was and how confusing it might have been. So really appreciate you being both of you being on the call today. I'd like to introduce you now to Dr. Gillian Kernahan, the President and Chief Executive Officer of St. Joseph's Healthcare London. Dr. Kernahan, also a member of our Rapid Response Expert Advisory Group for this report. And Dr. Kernahan, thank you for joining us and sharing some of your reflections and your experiences today.
Thank you, Julie, and thank you for being present. The first slide, I'm just going to very briefly introduce you to St. Joseph's Healthcare London. We are a multi-sided academic organization based predominantly in London, Ontario, but kind of spread across the region. We have 4 hospitals and a long-term care facility, family medical center, and distributed network of community-based and outreach services. We had a history of having patient and family councils because we do have multiple different populations, and I'm not seeing the slide come up, but I'm hoping somebody will move the slide to the next slide. There we go.
Thank
you. We did have a long history of working in partnership with our patients. The half moon that you see there is called our Care Partnership Framework that was designed with our patients and family councils. We have 7 patient and family councils across our organization to make sure we're being sensitive to the various populations that we serve. And we had done a lot of work co-designing the care partnership. We had done a lot of work around engaging, truly living our care partnership, where both our patients and family caregivers were fully involved in the organization in designing space and designing processes and setting priorities, as well as obviously in direct care for their loved one. We were very clear that a family caregiver, the family was defined by the patient, and so a family caregiver could be a friend, could be a neighbor, whoever they designed as the family caregiver. We were very privileged about 3 years ago to receive a large grant from the Change Foundation to advance our caregiver engagement work, and we called it Improving Care Together. And we had done a great deal of work. We co-designed that initiative with our family caregivers and patients and physicians and frontline staff, and focused on our family presence policies across the organization. Transitions in care was the priority that was established by our caregivers and our patients, and then continuing to enhance and deepen our care partnership model, where our families and patients really audited our space to make sure it was senior friendly and it was really sensitive to the people we were serving. So then COVID hit, and so if you go to the next slide, the COVID hit, and it was a provincial direction where, as you can see based on the dates, early in March, the long-term care first had their visitors suspended, and then March 19th the hospitals were, and the definition was very, very tight. So as an organization, we said, okay, there are principles around caregiver engagement. How do we transition that into a virtual world? And although we are restricted in physical presence, we can use the principles that we had developed around caregiver engagement and transition that. And so we did create an Engaging Care Partners during COVID framework for the organization. A virtual care toolkit and strategy was developed to assist frontline teams to meaningfully engage patients and families. We worked with virtual facilitators to create an individual plan for patients as to how they wanted to engage with their family and caregivers. And we have a care binder at every bedside that actually gives them the name of their team and what the team members do and what are the instructions. It's an individual care binder, and that was in the care binder, so at change of shift, all the care team members knew how that particular patient wanted to be virtually connected to the people that were important to them. We used virtual healthcare teaching for safe discharge with our caregivers. We'd walk them down the hall. We'd show them how to do transitions in care, and if that wasn't enough and deemed to not be safe, we brought the caregivers into the organization to be part of that journey. We continued our engagement with caregivers, although virtually, in policy and process development, to try and make sure that we were living the principles of our document, although we were restricted in how we lived them out. And we wanted to make sure that patients felt safe asking us to help them. So if you go to the next slide, I'll give you an example of what was posted on the whiteboards at the bedside, really to make sure that staff, patients knew that it was okay to ask staff. Although they were busy, yes, and we had opened 80 new beds in about a 2-week period and spread our staff, and we're very busy responding to the COVID response in our community and region. We wanted our patients to know that it was really okay, and we wanted to make sure they felt safe asking for help. Talking to our teams who coordinated this, it was very interesting that some of the learnings for our teams, we talk about the hashtag not just a visitor, and some of our teams who facilitated some of the virtual engagements with families came to have a much deeper appreciation for those family members who were truly essential caregivers and how much they did and enriched the life of their loved one. And that will inform the whole caregiver strategy as we go forward from here. They also appreciated, sadly, that there were a number of a subgroup within our organization that actually had no family caregivers, nobody that they could or wished to connect with, and how do we support them differently in their care journey. It was interesting that we have in some of our various programs, there may have been spouses who were together, patients or residents, and other patients or residents were quite jealous of people who could visit with their spouses because they actually lived in the same building. So it was interesting managing some of the equity issues that I've seen on some of the chat line in trying to understand the equity, where there were times we did bring in caregivers and why that was not sort of a universal policy. As we look at the next steps, and we do have the lifting of the restrictions to look at a phased approach to really getting back to family presence policies, we will be looking at it as a phased approach, and it's based on the prevalence of COVID, the capacity to do screening, because we have multiple sites and we probably have 120 new staff to do screening, and what's the capacity on each of the sites to do that, to the education of our family caregivers around IPAC approaches, because we did have in some places some challenging situations where people did come into the building and refuse to follow IPAC directions and refuse to sort of meet what we call mutual expectations. So being clear on what our commitment is to our family caregivers, but what the expectations of family caregivers, and that's outlined in the document as well. We're looking at common principles across our various sites because we serve very unique populations in all the different sites that have unique needs, and so making sure the principles are common, but the living it out is really sensitive and designed by the various councils. And so it will be unique to the population served. It's not a cookie-cutter approach. And we would co-design that with our family caregivers through our patient and family councils across the organization. And so we will focus on our higher need patient population first, a little bit of what you're seeing in the document that have a more immediate need, and then make sure that we're continuing on our journey to re-engage our family caregivers across the organization. So that's a brief synopsis of the journey we've been on.
Yeah, thanks so much, Dr. Kernahan. I'm just watching the chat box kind of explode here with lots of questions for you and comments about how you've done this at St. Joseph's Healthcare London. So thank you so much for sharing all of that information with us today. And I want to call upon our last speaker, our last panelist. Marianne Levasseur is a family caregiver from Quebec. Marianne was part of our Rapid Response Expert Advisory Group, and so pleased and thrilled to have her with us today and to share her experiences both as a family caregiver and some of her insights as being part of the group that helped to frame this document and the next steps that we've articulated. Marianne, over to you.
Thank you very much, Julie. I hope you can hear me.
We can hear you really well, and we won't be able to have Marianne on camera. We're having technical difficulties, but we can hear you really well. Thanks, Marianne.
So thank you very much for having me today. I'm sorry to everybody that you can't see me. We worked hard to try to get some video up, but it didn't want to cooperate. So you won't be distracted by looking at me. You can just listen to what I'm going to say. And today, instead of using slides, I decided on a more experiential perspective, which includes my own perspective in this time, and the perspective of other family caregivers that I work with occasionally. So I'll share this with you. Thank you. As a mother and caregiver for my son, I have helped him navigate the mental health care system, advocate for services and care, and interact on his behalf with many healthcare providers, institutions, and government agencies. My son and I have worked together for many years to improve his quality of life, and despite the challenges he faced in experiencing mental health problems, he was always optimistic about his future. My experience as a family caregiver of this bright young man has contributed greatly to the academic, professional, and research work I have accomplished in family engagement and family peer support in mental health care, and is still the driving force that gives me the strength and courage to speak to all of you today. In both my personal experience and my experience as a facilitator of family peer support, I understood early on that our loved ones depend on us for moral, medical, and often financial support, as well as care, reassurance, and the hope that things will get better. It is well known that family caregivers are recognized by healthcare professionals, researchers, decision makers, and policymakers as the silent providers of care and support for their loved ones, especially when they're patients. More recently, family caregivers have banded together to be recognized as essential partners in the care of their loved ones, making known their needs as caregivers so that their loved ones can receive better care. These needs may include information about the illness, medical training, financial help, respite, and peer support. As family caregivers became more integrated in health teams, they were reassured that their loved ones were receiving the best possible care. And as a result, the stress often associated with caregiving was and is relieved by the knowledge that patients benefit from a fully integrated healthcare team, which includes the family caregiver. So it was with shock and dismay that I and other family caregivers increasingly felt the fragility of their place in healthcare as essential partners in patient care during this ongoing COVID pandemic, as they saw themselves being summarily dismissed, turned away from caring for their loved ones, seemingly without regard for the potential dire consequences of doing so. And this not only in the immediate aftermath of the arrival of COVID, but as an ongoing action which has prevailed for months, even as it became glaringly apparent that keeping caregivers away from caring for their loved ones was detrimental on many levels. Family caregivers like myself were arbitrarily categorized as visitors who were barred from caring for their loved ones, their partnership in patient care completely disintegrated. The global presence of COVID has changed our lives in many ways, and in some ways irrevocably. What hasn't changed is caring for others, especially in times of need when those we love have limited capacity to care for themselves. Restricting family caregivers from providing essential caregiver services that increase positive outcomes for patients, improve the quality of their life, and add value to healthcare systems without cost is not a reasonable or viable option in a management plan for mitigating a pandemic. Based on my personal life experience as a mom and caregiver to my son who spent considerable time in hospital during his life, and based on my experience as a caregiver partner in healthcare, I believe the guidance given through this report on the reintegration of family caregivers as essential partners in care during a time of COVID is an important and necessary step to being prepared and to protecting all of our citizens to the best of our ability in times of crisis. Family caregivers are an important and essential partners whom both patients and service providers depend on for help. Without family caregivers, the gaps in our healthcare systems would become chasms, not just cracks. We have an opportunity to build a new framework that is supportive of patients, caregivers, and healthcare systems, but we must do it together. If we insist on leaving out key stakeholders as a result of being ill-informed or poor planning, eventually our foundation of family caregivers in healthcare will buckle under the pressure, leaving us without an essential natural resource in our many healthcare systems across Canada. Thank you so much for listening.
Marianne, I think if we could have applause, we probably would, for everyone who's on the line and all of us listening right now. Thank you so much. Yeah, Chris, give you some applause. Thank you so much for sharing. Thank you so much for your dedication to the advisory group and for your ongoing really important voice, not just in Quebec, but across the system. And I know you do a lot of mentorship for family caregivers as well. And so on behalf of family caregivers, I want to thank you for that as well. So we are going to go now into some questions and discussion with our panel, and that we had reserved more time, but such rich presentations from our panel, and I'm not going to mourn the loss of some time for discussion. I want to turn it over to Ward to lead us through some of the questions that we have here, and also some of the themes that are coming through our chat box with all of you on the line with us today. So Ward, over to you to guide our panel through a conversation.
Sure. Well, I might just throw out a question perhaps to Chris and to Jillian to begin with, just in terms of obviously policies around family caregiver presence are made at a high level in the province, perhaps by our medical officers of health. Is anybody really clear where those policy decisions are being made at? And does anybody know if patient representatives have actually been invited to the table for those discussions before these blanket policies are sent down?
I can't, sorry, Jillian, I can't tell you when the policies were originally set down as to whether there was consultation with Patient and Family Caregiver Council. Certainly talking to Matt Anderson, who's now the CEO of Ontario Health, which is a new single agency in Ontario. He has been meeting every 2 weeks with a Patient and Family Caregiver Council that sort of over the last number of weeks to really sort of guide some of the decision making. I think more on what it should look like as we start to reintroduce patient family caregivers into the system. So, but I can't speak to what happened at the beginning.
Yeah, similar response here, Jillian. Certainly, when the opportunity arose for us to kind of get involved and be involved, it was our opportunity to also recognize our patient partners and bringing them into the policy development. So the initial policy, I think, was sort of crisis determined and didn't have the same breadth of of that engagement as we've been able to try and move towards. So.
Okay, thank you for that. And Julie, maybe I'll just follow-up question for all the panelists in terms of, so right now we've seen some easing of the restrictions on essential caregivers, which has been nice to see. I think we still have a ways to go. My concern is that if we get a second wave of COVID and the crisis starts coming back and the perceived risk starts going back up again, are people going to be invited to the decision-making table differently this time around, and do we have any ability to influence that short of this report, and whose desk should we be putting it on? Maybe I'll turn it over to Sandy and Marianne in terms of their ideas. Do you have any perception of where being invited to a table or having some of your partners being invited to a table to inform the decision makers, whoever they are?
Well, this is Sandy. I think it's really important that patients and families have a voice at that table, because I think a lot of times it's control down, right? Especially in a case of emergency and things move really quickly. So I think it's really a good idea to maybe develop some type of mechanism where patients and families can be accessed quickly and at least filtered through so that the language is clear, so that if there's any red flags that families go, wait a minute, you never thought of this, that there's an opportunity to actually have that happen in those crisis situations. Because I think, as I mentioned, the language was what was an issue, and I think it has a ripple effect throughout how people interpret family presence and how they use the blanket directives. And if you're really family-centered, there's got to be a little bit of push and pull, and we need to have the language right.
Right.
Right. If I could just add on to that, it's Marianne. I think that sometimes what happens, whether it's a time of crisis or not, when we want to make a change in healthcare, when we want to, insert a different way of doing things, we get tripped up often over the process, and we decide that the process has to be a very complicated and big affair, and that 500 people have to approve something in order to get it onto the floor, in order to get it into practice. And actually, I remember reading a research paper once that said, sometimes the best implementation of new practices is making the smallest changes. So, in terms of a second wave and in terms of how fast we can get family caregivers to be part of the team in a more integrative fashion, we can maybe set up a 1, 2, 3 step where we're just, identifying the family caregiver, for that person, and then having a very short, session with them on a little bit of training, and then talking to healthcare providers about, how they can react differently to caregivers on the floor, with an open attitude and maybe a listening ear, and just, have them as part of the team. We don't have to do, I don't think we have to put, we don't have to go overboard with a big process to put in place, especially if there's a wave coming quickly and we want to be able to be prepared quickly.
So I want to get in here on the line of questioning because I want to get Ward involved in their answers, even though he's a co-host. So that is to all of you, but I'm thinking more specifically Ward and Chris and Jillian, you've all likely had interactions at your different, ministries of health or regional health authorities. What would it take to mandate family caregiver presence as essential or required as part of how healthcare is delivered? And I'm thinking, we support them accordingly. We make sure that they're treated like staff, which is one of the outlines in the report in terms of next steps. But what would it take to get this mandated and part of how the healthcare system functions so that it isn't as fragile and it doesn't go away in times of crisis?
Well, I think at the very least, board of directors, but Jillian highlighted the fact that it's above hospitals and above even probably regional health authorities in Alberta. So I think you need to get to the political level in order to really influence this, and medical officers of health, because during this pandemic, they're the people that really are in charge. I think even some of the politicians have to listen to them.
Jillian, I think that we have to remember in wave one, from the experience internationally, the feeling was that hospitals were going to be overwhelmed. That was when we went into wave one. That was the perception. I think we have a different perception for wave two, notwithstanding what's happening in the U.S. and the South at the moment. But I think we have a different perception of wave two, and we know how detrimental it was to families, to patients, not having their family caregiver presence. And so I think we need to plan for the personal protective equipment volume that would include family caregivers. That was a problem last time. We had enough to keep our frontline staff safe, far less bringing more individuals. And we need to sort of say that they are part of the team. They need to be counted from a volume perspective. The supplies would be available in all sectors to include that. I think we need to push out easy to understand training for family caregivers because the people in hospital now aren't necessarily people in hospital on the way too. So family caregivers needs to be easily accessible training on how to actually don and doff, so that it's not a responsibility of the hospital necessarily to train everybody in the midst of a crisis, but there's confidence that people have actually had access to that kind of training. And then I think we need to build it into our system. So accreditation has it as part of their standards. So you look at many sectors, and that's part of an expectation. And then I agree we need to get to the political and the public health, because most of us from accreditation, that's part of the new accreditation standards. But we need to get to the political decision makers and the public health, because the singular focus of risk was infection risk. In this, it wasn't a balance of risk. So how do we get that on the agenda? But I think it needs to get to both of those. I would agree with Ward.
Thanks, Jillian.
That was so great, Jillian. I was furiously writing this big list of those specific actions as a hospital CEO that you need to have in place to be able to support this. Back over to you, Ward. Apologies for the interruption.
No, I was trying to keep track of the chat box, and there's lots of great questions coming through. I think one of the things I noticed is going along with this idea that some patients are hesitant to actually name a caregiver, even if they do need somebody, and how do we support people or help people? And again, I might turn to Sandy and Marianne for advice in that, because some people don't naturally reach out for assistance from their family or their neighbors or their friends.
This is Sandy, and I think the key is really to talk about the patient and family. Not every patient and family need, want, or desire to have a caregiver in hospital with them. And I think that's what patient-family-centered care is about, is everybody is unique. And so for my experience of a disabled daughter, I need to be there. I'm her voice, I'm her advocate, and I'm also there for safety reasons. So looking at me compared to maybe my mother, who is able to communicate to herself, she might be okay to link with me on technology so long as someone supports her with that technology. I may not need to be in hospital with her, but part of that communication team. So it depends on the patient and the family, and I think that's what we really need to look at, is having that flexibility built in to make the best decision at that time for that patient.
Brilliant.
I wanted to, if I may, Ward, ask a follow-up question. So it's about, you're asking about, what if you don't have a family caregiver or don't want one or don't need one? So that, it's not essential. You don't have to have someone at your bedside, but if you don't have a loved one, how do you identify a support person? The other question or theme that's come up in the chat box quite a bit is many people are reflecting who are active family caregivers at the time right now and who've been restricted from care, that they feel there's been a damage in the relationship with their healthcare team and with their hospital. They're stressed about when they can come back and what that's going to look like. How welcomed are they going to be? What is that partnership and care experience going to be like? They feel traumatized, and there's a real issue of trust now. And so I'm wondering if I can open that to the panel. It's a tricky topic, and it's a stressful topic, both for frontline staff and hospital leadership, as well as the family caregivers and patients. But can we address that one? What do we do about the damage and trust that's occurred?
Yeah, it is such a difficult situation, and I mean, I think the aspect to remember about this as well is that for so many of our healthcare workers, this has been a huge source of moral distress to them as well, in terms of trying to put these decisions forward. It's things that they wouldn't desire to kind of block people from having that access. So there is some real emotions around all of this, from certainly from the patient side, but from the so I think it's coming together and trying to recognize that there's some healing that needs to be done going forward, and really trying to open it up, the conversation, and recognize that this has been a painful experience for a lot of people.
And I would agree with Chris that it's the recognition that this was a really bad situation for everybody involved, and we need to move forward. And how do we move forward with that? And opening the lines of transparent communication is I think, really key to being able to work together.
I also think, Julie, that trust is earned. So I agree with Chris that this has been very difficult for our frontline teams, that they would like to have had family caregivers there, but the provincial guidelines said they couldn't. And so I'm hoping family caregivers understand it's not the frontline staff that banned them from being there. It was a directive that they were mandated under an emergency order to follow. So I'm hoping that there's a way of kind of stepping back a little bit and understanding that. I know it's hard in the emotion. I am a family caregiver. My husband's in long-term care. I didn't see him for 3.5 months, even though he was in my own organization. And so it's something that, having had personal experience and professional experience. So, but I also think the trust is earned. So I think we need to, as organizations, really think about how do we, although we may have a great family caregiver relationship before, we need to understand we need to re-earn that as we reintroduce people back, and not be judgmental and react when people may be reacting negatively in a way that we may not understand. So I think that part of that is our sensitivity to our staff as we begin this journey back together. So.
Thank you. Ward, might have time for one more question. Do you want to take the last one?
Well, I just saw an interesting question come up from Terrell about, can healthcare facilities push back when getting a directive from high and above? And it sounded, Jillian, like your organization sort of adapted a little bit to the directive that you were given, and maybe led some interpretation into that. And
we made some exceptions where we thought it was truly at a point where it was really in the best interest of the person we're serving, but we really adapted it to be a virtual engagement in a really dynamic way, as the patient wished it to be, which I think has helped continue some element of trust in that journey.
So I'm going to have to leave it there, and very conscious of time here as we get into 1 o'clock. Thank you all so much for your participation in this, and deep thanks as well from our organization for participating in this work for the past 2 months, all of you, Dr. Kernahan, Dr. Flemons, Chris Mayhew, Sandy Opal, and Marianne Levasseur. I do want to invite our guests who are with us on the call today, if you'd like to stay on for a moment and participate in just our quick sort of continuous quality improvement survey. You're welcome to do that and fill out a couple of just 3 quick questions. And we will have this webinar has been recorded. We will be sharing it with you online to our CFHI website, and we'll be capturing all this incredible dialogue in our chat box as well, and noting there's a lot of questions and comments here that we'll try to include in a summary as well. So thank you all. Have a wonderful day. Thanks for paying such great attention to this report, and I'm wishing everyone the best.